Welcome to this explainer. You know, every single day, thousands of people around the world get a miraculous second chance at life through a kidney transplant. But the very second a surgeon restores blood flow to that brand new organ, boom, a microscopic battlefield immediately erupts. Today, we're diving deep into the absolute fundamentals of this conflict to figure out exactly how and why the body fights back. We're getting right into why allograft rejection occurs 101. So, we've got to ask the big, crucial question right up front. If a new kidney literally saves a person's life, why on earth does the body try to destroy it? Well, you have to remember that for hundreds of thousands of years, our immune system has been ruthlessly fine-tuned for one job, keeping us alive. It's totally hardwired to hunt down and obliterate foreign biological material, stuff like deadly bacteria, viruses, and parasites. It literally has no concept of a life-saving surgery. So when it bumps into a newly donated kidney, our cellular defenses treat it exactly like a massive, terrifying pathogen. It's really just doing the job it evolved to do.
To make sense of this whole cellular conflict, here's how we're going to break it down today. 1. The transplant immune dilemma. 2. The T-cell infantry attack. 3. Antibody-mediated missile strikes. 4. Rejection timelines. And finally, 5. Spotting the cellular damage.
All right, let's jump straight into section 1, the transplant immune dilemma. Let's look at what an allograft actually is, a tissue or organ transplanted between genetically non-identical individuals of the same species. Now, what's really fascinating here is how the body actually knows the organ is non-identical. Basically, every cell in your body wears a specific set of molecular ID badges on its surface. We call these human leukocyte antigens, or HLAs. Your immune system is constantly patrolling the bloodstream, literally scanning these ID badges. So when it encounters the donor kidney cells, it reads an unfamiliar HLA badge. And wow, that mismatch is an immediate call to arms. The immune system sounds the alarm, flags a tissue as non-self, and kicks off a highly coordinated, multi-pronged attack to take out the perceived threat. Which brings us to section 2, the T-cell infantry attack. Before we get into the battle damage, it's pretty amazing to note that thanks to modern therapies, the frequency of clinical acute cellular rejection has actually been slashed down to just about 10% of transplant cases. That is a massive triumph for modern medicine. I mean, before these drugs, severe rejection was almost a guarantee. But to get that number down to 10%, that requires incredibly intense, powerful medical intervention. So when an attack does manage to break through that chemical shield, it is a remarkably aggressive, highly organized assault. You can really think of the specific type of cellular rejection as a coordinated infantry assault. It's led mainly by frontline soldiers called T cells, alongside their heavy-hitting partners, macrophages. Once they're deployed, these cells literally march out of the bloodstream and straight into the newly transplanted kidney. They systematically invade the interstitial tissue, which is kind of the structural scaffolding of the organ, as well as the tubules, those vital little microplumbing tubes that actually filter our blood. Pathologists call this specific invasion tubulitis. These immune cells also attack the delicate inner lining of the blood vessels, causing endodermitis. And this brutal, localized, hand-to-hand combat is driven by CD8+ and CD4+ T cells. These cells release chemical signals called cytokines that act like flares, drawing in even more troops and just multiplying the destruction. Take a look at the violent aftermath right here. This is arterial fibrinoid necrosis. See that super intense, bright pink ring? That's the badly damaged wall of a small artery inside the kidney. It is completely swarmed by immune cells, showing severe tissue death or necrosis and massive inflammation. This isn't just some abstract chemical process, guys. This is the direct result of immune cells physically tearing apart the structural integrity of the organ's vital blood supply. They're literally choking the kidney from the inside out. Moving on to section 3, antibody-mediated missile strikes. Now, compare these two totally different styles of warfare. While cellular rejection relies on T cells and macrophages for that close quarters, hand-to-hand combat in the tissue, antibody-mediated rejection operates entirely differently. It is essentially a long-range missile strike system. Instead of T cells, it relies on B cells, which act as microscopic weapons factories. These B cells pump out specialized Y-shaped proteins called donor-specific antibodies, or DSAs. These antibody missiles passively float through the bloodstream, lock onto their specific targets on the donor's blood vessels, and then trigger an absolutely devastating chain reaction known as complement fixation. Let's dive a little deeper into that complement fixation, because it's incredibly important. The complement system is basically a domino effect of proteins circulating in your blood.
When they're activated by an antibody, they literally assemble into molecular drills that blow holes straight through target cells. To prove these long-range missile strikes actually happened, pathologists look for a very specific footprint, C4D. When the complement cascade gets triggered, a specific protein is split, and a tiny fragment called C4D binds covalently to the surrounding tissue. That means it attaches permanently and irreversibly. It acts just like a durable, lasting fingerprint left behind at the exact scene of the antibody strike, often sticking around long after the initial attack is over.
Notice those glowing green areas? That is the C4D fingerprint in action. Under a microscope, those intensely bright, glowing segments prove that the antibody missiles successfully found and hit their targets. The specific stain we're looking at is highlighting that C4D protein permanently trapped within the kidney's peritubular capillaries. When a pathologist sees this widespread green glow, there is absolutely no doubt. It unequivocally confirms that a stealthy, antibody-driven war is raging deep within the microscopic blood vessels of that new organ.
So, the huge takeaway here is this. Donor-specific anti-HLA antibodies are detected in 90% of these C4D-positive acute rejection cases. That correlation is just staggering. If that glowing green footprint is present in the tissue, the circulating antibody missiles almost certainly caused it.
All right, let's look at Section 4, rejection timelines.
So, how long does all of this actually take? Well, rejection isn't just a single, predictable event. It can strike incredibly fast, literally within minutes or hours of the surgery. This happens if a patient is what we call presensitized, meaning they've been exposed to foreign tissue before, maybe through a blood transfusion, a previous transplant, or even pregnancy. Their immune system already has the weapons loaded and waiting, causing hyperacute rejection. Or the attack might happen in the 1 to 6 week window, as the body slowly figures out the organ is foreign. That's your acute cellular rejection. Finally, it can be a slow burn, taking months or even decades in the form of chronic allograft nephropathy, which just quietly and continuously destroys the organ over a long period of time. You can see the devastating, immediate impact of hyperacute rejection right here. Like we just talked about, this happens when a recipient already has millions of circulating antibodies specifically primed against the donor's tissue type. The very second the surgeon unclamps the vessels and restores blood flow, those preformed antibodies swarm the new kidney. They attack the endothelial lining of the vessels instantly. What we're seeing is extreme congestion, capillary neutrophils rushing in, and severe hemorrhage. Massive blood clots form inside the new organ, and tragically, the graft can completely fail before the patient even leaves the operating room.
Now, on the completely opposite end of the spectrum is late graft loss. It's really important to understand that if a transplant begins to fail 5, 10, or 15 years down the road, it's frequently not just normal wear and tear. Instead, it's the silent killer of transplants, a continuous, slow-motion, chronic antibody-mediated rejection. It is a persistent, low-grade war of attrition, operating completely under the radar. It slowly replaces beautifully functional filtration tissue with useless, rigid architectural scarring. And honestly, by the time it's finally detected, significant, irreversible damage has usually already been done.
And here is the aftermath of that long-term war of attrition. Notice those thick, double-contoured pink loops. This captures a condition called transplant glomerulopathy. Because of those chronic, low-level antibody attacks over years and years, the kidney is constantly injured and frantically trying to heal itself. This forces the kidney to abnormally duplicate its own basement membranes in a desperate attempt to repair the endless damage. It is literally architectural remodeling, driven by an unrelenting immune system that just refuses to give up.
Finally, let's get into Section 5, spotting the cellular damage. Pathologists really have to act like elite medical detectives to piece together exactly what is happening to a failing organ. On one side, you have that fiery, destructive, acute tissue death that's characteristic of an active, overwhelming infantry attack. But then on the other side, you see the chronic, thick architectural scarring resulting from years of slow antibody missile strikes. By reading these microscopic clues, distinguishing between an acute cellular infiltration and chronic membrane duplication, they can piece together the exact history, timeline, and mechanism of the immune attack. And that is exactly what allows clinicians to properly tailor their life-saving treatments.
But it isn't always a clear-cut case of the immune system attacking the organ. One of the biggest diagnostic challenges in transplant medicine is distinguishing true immune rejection from severe drug toxicity. And this brings us to a terribly cruel paradox. The powerful immunosuppressive drugs, like cyclosporin A, which are absolutely essential to protect the kidney from rejection, can actually cause profound toxic damage to the kidney themselves. This is called calcineurin inhibitor toxicity, or CIT. CIT causes vessel damage that perfectly mimics an immune rejection. Think about that. The cure is literally acting as a poison. But the crucial distinguishing clue for the pathologist looking under the microscope is that drug toxicity uniquely lacks the massive cellular immune infiltrates we'd normally see in an active immune rejection. It's the exact same damage, but without the soldiers present. Which brings us to a final, pretty profound thought. In transplant medicine, we are constantly walking a dangerous tightrope. If we push too far one way and don't suppress the immune system enough, the body's defenses will ruthlessly destroy the new organ. But if we push too far the other way to protect the organ, those very same drugs can become toxic and destroy the kidney, or leave the patient fatally vulnerable to basic infections. The holy grail of transplant medicine is achieving true immune tolerance. The question is, will we ever crack the code to teach our highly evolved, deeply suspicious immune system that this specific foreign invader is actually a friend? Until then, this microscopic battlefield remains one of the most fascinating and complex frontiers in modern medicine. Thanks for joining us for this explainer. We'll see you next time.